Hi, Russ. This is Barbara Wash from the Department of Medicaid Services. It is 12:58 and I'm still clearing the waiting room.
Good afternoon, I guess. Let's see.
I only see you on here so far, Russ.
So I know Elaine told me she couldn't be here, but I thought the others could, but we'll see. We'll give them a couple minutes here, see what we got.
Okay, okay. Okay, Russ, it is 1 p.m.
Okay.
I do believe I saw Lori on there. Yep, I do see her.
Hi, Lori. It's just you and me right now. I know Elaine asked me she couldn't be there, so we do not have a quorum. I need one more. So
Now, I saw La Michelle, but I wasn't sure.
I
Um,
got Michelle. You got Michelle Tyson from DMS.
yeah,
Michelle Clark. I don't see Michelle Wallace.
no, I don't. Do you want to give it a minute or so, Russ? It's up to
Yeah,
you.
we'll give it like a couple minutes and then we'll just get into the agenda without any voting
Okay,
recommendations or approved minutes or anything like that.
okay.
All right, let's go ahead and get started.
Okay. Well, the waiting room is clear. So,
Okay, we'll catch
okay.
up.
Okay.
Uh, Good afternoon, October 28th, 2025, Hospital Technical Advisory Committee. This is Russ Ronaldo, the CFO of Owensboro Health. Lori, you want to introduce yourself? I know you're an TAC member that's on the phone.
Sorry, I was trying to get off mute.
Okay.
Lori Ritchie Baldwin. I am the CFO for St. Elizabeth Healthcare in Northern Kentucky.
Thank you. Okay. We'll do the minutes next time. We have a quorum. So we got new business. The first one is, this is a kind of almost a revisit of a discussion we had. We've had multiple discussions about I think the appeal form that, and we had an issue with passport at one point in time where if there's as I understand it, if the documentation didn't fit in the box and they said, you know, we didn't have enough room to put the information, and it said, the provider would say, see attached sheet, those are getting rejected, saying not on the correct form. I thought we had resolved that, but I continue to get information that Passport is still sending the notices that say not on the correct form. I don't think, you know, what we understand is that they don't have the ability to deny the review. We just want to make sure that that any of the appeals are reaching the iPro, um, or are they being turned away based on the Passport language if Passport's saying they're not on the correct form.
Don't know if we have anybody here from Passport.
Well, can we take can DMS take, I mean, I just want to make sure that, you know, if the hospitals are submitting for external reviews and they're getting a notice back not on the correct form, I thought we cleared this with the cabinet and with DMS and Passport, but we're still seeing those. I just want to make sure that those are going through to the iPro and the iPro is reviewing those. So Passport and, you know, so we need to get that answer from Passport and so I'm asking DMS to get it for us.
Don't know if anybody here from DMS would respond to that. If not, I could bring it back, Russ.
Okay, thank you.
Mm-hmm.
The second issue, we've got prepayment reviews. So as I understand it, and I think Lori, you guys are experiencing this, WellCare is putting claims on what the hospitals perceive as prepayment reviews. It's an Optum program, and being told it's being hit for fraud, waste, or abuse. The hospitals aren't being told what is triggering the reviews. And so it's kind of going through the way the OIG safeguards around prepayment reviews from our view. WellCare promised a suite of reports, did not we did not get those the way we expected them. Um, it was just a training to pull down additional information from Optum. So I know this has been discussed in the MCO arena with our biweekly calls. We can't have payers put the providers on prepayment review without reasons, without going through a process. There has to be a reason. There has to be samples. It can't just review every claim or put a group of claims on prepayment review for no reason. Rosman, you want to add anything to that from what you heard?
I think you covered it, Russ. I mean, I know that you know, it is a tremendous effort, and you know, we want to thank WellCare really for trying to pull the suite of reports together, but it just doesn't close the loop in terms of information that the hospitals have expressed concerns about. As you mentioned, looking at the you know, reasons for the prepayment review and getting all of those safeguards from the OIG as well for prepayment review.
From WellCare?
Yes, hi Russ. This is Kathy Davis with WellCare. We can definitely take this as a follow-up item. I would like to, and I can connect with Rosman, or if you have a specific facility, to get some more detail about what the facilities are looking for in the suite of reports that is not there.
Okay. As I understand it, what I was told is that it's the reports that were given was really just training to get information from, to try to pull down information from Optum, right? And I guess my expectation would be Optum would be pushing it out, or the MCO pushes it out, right? I mean, if it's truly prepayment, it should be similar to what we get from Medicare, right? We've noticed this issue or this outlier. Here's what it is. We're going to do sampling. We're going to do these reviews, and then you come back and say, here's the results of the reviews, and then there's a discussion period where there's education, and the whole idea is to 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 to, to try to address it so that you're not on prepayment review. It can't be an evergreen, and that's what I'm kind of hearing from some of the providers. They feel like it's an evergreen. They don't understand why. They're never, they don't know how to get out of it. They don't know what really, some of them don't know what the issue is and how they've been put on it. So just trying to build some transparency on what's going on and how we address it.
Absolutely. We can, I will take that as a takeaway. If any facility wants to reach out with specific questions, we can gladly do that. And then we can connect offline about the suite of reports and exactly what we're looking for.
Yeah, thank you, Kathy. Jennifer, you're talking. I don't know if you're talking to us, if you're on mute.
I am off mute. Can anybody
Okay.
hear me?
I can hear you now, yes.
Okay, that's weird, but and so I'm Jennifer Nudinsky. I'm the division director for the Division of Program Integrity with Medicaid.
Okay.
And so I haven't heard anything about any prepayment issues. I don't know if you're speaking just of well care issues or if there's other MCOs that you're having issues with as well. But any of the prepayment reviews, just for informational purposes, those have to come through the department and we actually approve what the MCO is wanting to do for that prepay. So there is a formal process that has to be followed. So they will submit that to us. We have two different groups that review that and approve it. So if there is anything that we can do to help kind of mediate a situation, you can reach out to me and I'm happy to try to help navigate maybe what the problems are. And I'll put my email address in the chat.
Okay.
Again, I don't know specifics. It's not something that's come to my attention before, but I will put my email address in the chat for you. And if there's anything I can do to help, if you're, unable to make any headway, I'll be happy to try to help.
Okay, that's great. I appreciate that. I think, yeah, and I don't think that they've gone through the prepayment reviews, but the perception is that it's performing like a prepayment review in the provider's viewpoint. So, okay, I appreciate that. Thank you, Jennifer. We'll get information out to those and try to resolve this. Okay, the SB 20 backlog, I think still wanted to keep us on there, ask for an update. I know we had, the last time I heard, I think we had 2,500 pending cases. I know I continue to get requests from some MCOs asking for refunds on things that are still in the process. Wanted to see, I know that we had some that were missing acknowledgement. I know there were several that had missing acknowledgement, missing determination letters. uh, I'm trying to, look at the notes that I have. Any progress on the backlog that we know?
I don't see anybody unless somebody's trying to come off of mute.
Okay,
I could bring it back.
yep, that's fine.
I'll bring it back, Russ.
Thank you.
Mhm.
So I think the behavioral health items,
An update on some of those, Russ.
thank you, Nana.
Yes, the DMS provider notice, that was where the providers were waiting for communication from DMS authorizing telehealth for PHP and IOP. On our DMS KHA call on 10/17/25, Justin Derringer, we asked him about whether or not there was going to be a provider notice coming out. We've been asking for this for over a year and a half. And I reminded him that the commissioner back in January of 24 had said that CMS had approved that telehealth for PHP IOP. And so Justin said that providers should go ahead and proceed with that service delivered in that way. And that if there were any denials, we should let him know.
Okay,
Hello, how are you?
hi, Justin.
Good. Is there
Hey,
anybody
Justin.
from behavioral health on?
I-
Hi, this is Sherry. I'm here.
Sherry, do you know if that notice went out or if we're still I couldn't remember where we're at with it.
I think we were waiting on the updated CMS guidance since they had just released something new. And we're trying to get confirmation from them. So yeah, the issue was figuring out the exact dates that those things were rescinded and then just making sure we have the most updated guidance from CMS.
Thanks, Sherry. You know, we still, I think, have an issue regardless of what CMS comes out with now. We've got the retroactive issue of not being able to provide that service since January of 24. And so I hope that we can get some resolution on this. It's been on the agenda forever. And so I've gone ahead and told the UHS hospitals at least what I heard on that call on the 17th. But we need to let the whole behavioral health community know what the answer is. Thanks, Sherry.
Sure.
Yep. Thank you, Miss Staley. As soon as we find out, get confirmation back. I had to check on that. I can't remember. I know we'd sent that to CMS several times. I think they've been extremely limited in their communication with us due to this shutdown. So
Sure.
I'll check back again today and see if we got any response back. I know we got a very limited, vague response the first time. We asked for more clarification, and I think we may still be waiting that. So
Okay.
But just to clarify, is the guidance still to go ahead and follow through with what we heard in our DMS call and let providers know that they can provide the service? I just want to be clear.
it is. There are, you know, I think that's why we're hesitant. That's why we've been waiting. I mean, there were so many changes. So initially, we had the public health emergency where we were able to utilize those benefits, and then CMS came back after the public health emergency with information saying now you can't do that. And then they made a change later. They came out with more information, and Commissioner Lee confirmed it, saying, okay, now you can. But then they also came out with guidance recently that was very conflicting um, because they, removed that, or they let lapse that um, that one provision that they were using to um, allow that to us to use telehealth for that. So, it's one of those things where, we could for a while, right after Commissioner Lee confirmed it. I think what is the stressor is what are the dates? What are the dates that we could? What are the dates that we couldn't? That's what we're trying to confirm and put with you all in a letter. So at the time we talked about it, yes, you could absolutely provide those services. Right now, can you? That's what we're trying to find out. So we have to follow federal guidance, you know, first. And so that's why we haven't put out any provider notice yet. And we're just trying to get the dates exact. So once we have that, we can give those to you all. And I know it's muddy and convoluted, and we're trying our best to get some precise. And normally we would already have that, but when the government shut down, CMS's communication shut down with it. Not in everything, but definitely it seems in this instance. So as soon as we know, you will know.
Okay, well, we thought we knew previously, in
Yeah.
the meeting. So I just, what we discussed is that we have an approval and have had for some time. But the fear is that if those services are provided without an official memorandum from the department rescinding that previous guidance, that the MCOs will not pay for the service. So based on what we heard, the direction was to follow that approval and go ahead and provide the service, and that if the MCOs did not pay for it, they should reach out to you.
That was correct at the time. And then we were now, again, we're trying to find out whether this recent development has allowed us not to do that. What do you remember, Sherry, what date that expired? I don't have that in front of me. There was
Well,
a,
the affirmation from Commissioner Lee was January of 2024.
that's correct, but there was a expiration date federally that they let lapse.
I think it was like May 2024. I will look for the current CMS guidance. It's on the CMS webpage and send it so you guys have it and can look at it for yourself. Like Justin said, it is confusing. It doesn't lay it out clearly. And we just are wanting to make sure that we're giving you the correct information from CMS.
Yeah, we had several
Well,
months
as
there
you
where
guys-
we had some clear guidance and it was acceptable to use to move forward. And then, then CMS, it came out with some muddied guidance after that. And so, yeah, I think it seemed like it was in September, maybe, Dolan, Miss Dolan, something like that, when something came out from them that was even more, when we'd reached out to CMS and it was even more muddy. So,
Yeah, it's unfortunate because in the meantime, there are a lot of patients,
sure.
particularly in remote locations, who could benefit from the service who haven't been getting it and who now are getting it. So hopefully we will find out soon because otherwise the hospitals could be at risk. Thank
We're doing
you.
we're doing everything we can. So as soon as we know, you all will know.
Yeah.
Thank you.
Thank you so much. Just to be accurate on the dates, I think it was September 30th when the telehealth flexibilities lapsed
I believe that's correct.
due to the government shutdown. But the meeting
So,
that we had with you, Justin, was October 17th.
okay. Of 20,
Couple
Just
weeks ago.
2 weeks ago.
okay.
Yeah.
All right.
Okay. And Russ, on the next item, I think it's IMD, not IMD PHP.
Yep, I think you're right.
Yeah, so the IMD issue, as you all know, varies by MCO. And the IMD, for those that may not be familiar, is the Institutes for Mental Disease back in the 1960s, where the federal government came out and said that patients, Medicaid patients between the ages of 21 and 64 could not be cared for in a freestanding psychiatric hospital. And then over these many, many years, that has been approved by CMS under certain conditions, the MCOs could provide or could approve and pay for IMD services. What we have now is that of great variation by MCO. Some will pay 15 days in a month, and it's the language is if care exceeded 15 days in a month, it could be denied. And so some MCOs are going by, what we believe is a different interpretation. And if it's 15 days in a month, they'll pay just the 15 days and no more. Some say that if it's greater than 15 days in a month, they'll pay nothing. And then others say if it's greater than 15 days, they'll pay the 15. And then upon clinical review, they may authorize additional payment. So I believe, Rosman, if I'm not correct, I think we're waiting on an interpretation of that from DMS so that we can get everybody on the same page.
That's correct. We are awaiting an interpretation.
And we are also reaching out to them, to CMS again, about clarification regarding, the new 60-day policy that we're looking at for SMI 1115. So those were the exact questions we asked. If they stay 61 days, does that nullify the entire stay? If they, stay less than 60, those can be paid by the MCO. Those will no longer be in lieu of service. Currently, those are set up as in lieu of service. And so the MCOs can voluntarily choose to pay those. They are not mandated to pay those. So I think that's what's been the issue. But yes, we have asked CMS to please give us guidance about if they stay 61 days, does that nullify the entire stay? We believe it does because it's just the short-term stays, and making sure that if the MCOs are paying, they are, aware of all those rules as well.
I've never heard 60 days ever.
Well, that's for the new one, right? For the SMI 1115. So we are reaching out about that for questions, but it would help us understand the current 15-day rule because it would be the same advice. What we've been told is that we have to maintain, we can't have an average of more than 30 days with the new 1115 I'm talking about. And so we have to keep track of the statewide average of lengths of stay. And so we're working on reports to be able to do that.
Now I'm even more confused.
So the 15 days is what you guys are currently dealing with, and that's
right.
in lieu of services. So
What does that mean in lieu of services?
I don't know how to really explain it. Federal Managed Care Regulations 42 CFR 438.3 allows MCOs to cover short-term IMD stays as an in lieu of service. Under this provision, an MCO may elect, but is not required, to treat inpatient IMD services up to 15 days per month as an alternative to a covered inpatient hospital stay. The state Medicaid agency may authorize the use of IMDs under an approved in lieu of service policy, but cannot compel MCOs to contract with or reimburse IMDs. Kentucky's managed care contract allows IMDs as an in lieu of setting.
That language I am familiar with, so.
Not anything else on that?
No,
So the
It's-
the PHP, I thought, maybe I meant IOP. I heard the IOP with Anthem issue. That
Well,
they-
we have PHP, IOP telehealth issues, which we've already discussed.
Okay. All right.
So.
The Anthem issue not being counted on a rolling week, that's been addressed. That's still.
Oh, yeah. And well, the other thing that came up on the IMD 15 days is on our MCO calls on the 17th, there was a hospital who got a patient who had been in prior treatment somewhere, and they tried to identify how many days of care had already been provided, and the MCO wouldn't provide that information because they said it was HIPAA, and the hospital didn't need to know whether or not who the patient was or even where they were, just how many days of care had been provided. And so that's just one more thing as we proceed with clarifying this issue. Hospitals need to be able to contact the MCO and identify if care has already been provided somewhere else, and if so, how many days.
Justin has his hand raised.
Justin.
Yes. So going back to the partial hospitalization issue, are you all getting claims denied?
Well, very few hospitals that I know of have done it, but the ones that have not had claims denied.
Okay, I'm just making sure because
Yeah,
I think I
that's
did
it.
tell you all that if you have claims denied, then send it to me.
Yes.
Because you all did. Somebody received an email from Commissioner Lee.
Yes.
Okay, and we haven't sent any official guidance unless you've got an email from Commissioner Lee, Deputy Commissioner Judy Cecil, um, Deputy Commissioner Dr. Hoffman, or one of the other directors. Then that was the last guidance you all received.
Yes, sir, that's correct.
Okay, so that's the
Mhm.
guidance you need to go by. I just wanted to kind of clarify,
Yes.
but I also wanted to explain so that I did see the text or the message that's I don't want to talk out both sides of my mouth. We're still support that guidance if you all have any denials, but because of the dates and we're making sure we try to get everything exactly correct. That's why we haven't had that clarification for an actual, provider letter yet. I
So
hope
it
that
sounds like we
clarifies a
just,
little bit.
yeah, we just proceed until we hear otherwise.
That's correct. You proceed with the last guidance that you've received.
Thank you.
You're welcome. Sorry, it was, if I was confusing before.
It's okay.
Ron, are you good? You okay?
Yes, sir.
Okay.
Yes, sir.
Thank you.
Okay.
Appreciate you.
Mhm.
All right, going into denials. First one, newborn prior auth. So we've got a couple issues here. We've got we have several instances with multiple MCOs where newborn claims are denying in total and whole. Because they have because the DRG, it's diagnosis related group, it's diagnosis based system. Diagnosis goes to a DRG that is not necessarily a normal newborn. And there was no NICU stay on the bill, or the hospital didn't have a level 2 NICU. And so the MCOs are denying no newborn claims in total. They should be able to deny newborn claims. And again, they should be able to deny a claim saying that you didn't have an accommodation code, and that's the reason why we're not going to pay you. Like saying I have a surgery, an open heart, and I didn't have critical care or ICU or CCU stay, then you don't get that. You didn't do that. You don't get that DRG. It's becoming an issue, and we need somebody from DMS to help navigate it because it's a problem.
So Chelsea has her hand raised.
Chelsea?
Hi, yes, good afternoon, everyone. Just wanted to update you all that we have an internal meeting scheduled actually for tomorrow with our medical director, our Division of Healthcare Policy, the contract monitoring branch, to discuss this issue and to make a determination about the guidance that DMS would give. So I don't have an update unless Justin has anything additional, but I don't have an update for that today. I will know tomorrow a little bit more after that meeting takes place, though.
Okay.
No, I,
Have you-
I do want to let you all know that we did review that. We read multiple cases and we're going to talk about it internally and then get back with you all.
Okay. Does that also include where they're requiring an off? You know, all babies are retro, but we're getting denials because say we didn't have an off on a baby that ends up being something other than a normal newborn.
Yeah, I believe there were
Yes.
several cases that were that way as well.
Okay. All right.
And just, I'm sorry, I'm gonna jump in, Russ, just for our DMS partners. Do you have examples? It sounds like you do, but I just wanted to make sure.
We do. We have several examples.
you.
If there are more though that you think are outliers or that we may need to look at, we're more than happy to take a look at those too.
Well, we don't see the examples because, they're not redacted. So as long as you have some,
We do.
Perfect. Thank you.
Okay.
Okay. Thank you. All right. DRG downgrading. This is an issue that's been on our list since May of 24. In our most recent October meeting, we had WellCare, as I understand it, pushing back, saying that they're not DRG downgrades. They can't substantiate the DRG. So WellCare is doing reviews and providing no payment. And the hospital is getting no payment on an inpatient, even though it's been authorized. There's medical necessity. They're looking at it saying, okay, if it's DRG 101, I can't substantiate that. Typically what happens with the MCOs is you there's a review, and if there's a diagnosis that the MCO disagrees with, they may propose a change in the DRG based on the diagnosis that they don't agree with. And then the hospital has appeal rights. There's no indication of fraud, waste, or abuse. The hospital doesn't know what the difference is. All they're being told is that WellCare can't substantiate the hospital's DRG. So there again, this, it's a full denial for something that was authorized. And we can't, we're spinning our wheels, and we need DMS to help us navigate it. So DMS, how do we want to attack this? Because it's been there a long time and we're getting nowhere.
So I believe Jeremy or Chelsea, either one of you that are on.
Yes, I believe Jeremy might be out today. If he's on, that's fine too. If he has anything to add, that's fine. So working with KHA, my branch has been developing at the request of the KHA. We've been developing a reporting mechanism to get a handle on understanding the DRG downgrades, the percentages of, that this is happening. We would like the MCOs to report that information to us because we're trying to identify, like you're saying, outliers, right? We're trying to identify areas where we're seeing this excessively. It does take some time to get reports developed and up and issued. So, that's been a little bit of a challenge over the last couple of weeks. But all that to say, this is something that we are, trying to understand, trying to get a handle on, and trying to determine, what the best way to assist you when you're getting these.
So and I appreciate that. I think the, the reason this is a little different animal, WellCare is saying they're not DRG downgrades.
Okay.
They're
Okay.
saying they can't substantiate the hospital's DRG, which is new. And
Right.
they're not paying anything. So again, in a DRG downgrade, which happens and occurs, and there's appeals and discussion. Again, if I have an authorization for an inpatient and I bill a DRG 100 and the MCO reviews the record and disagrees, they come back and say, we don't think this diagnosis is substantiated. This is why we think it should be a DRG 101. We propose to pay a 101, and then we can appeal it. But we've not had an MCO until this point say we're not going to pay the authorized case at all. I called for an authorization, got the authorization for care because we can't substantiate your DRG.
Hmm.
It's and then them not saying it's not a DRG downgrade, so it's a pure denial. And again, you've got the authorization. It's so this is a little different animal than just the DRG downgrades.
Okay. And I've just, have there been any examples provided to either the CMB branch or our healthcare policy branch? Is anyone aware? For the new issue? I know we've had some examples just previously, just in general about the DRG downgrades, but since this is kind of a newer issue that's popped up.
I would ask Rosalind, do we know if we've gotten examples to them?
Hey there, I'm checking to see in our last log because I usually like to document it there if we've sent examples so that I can kind of track the length of time on those. So let me pull that log up really quickly and I can either respond in the chat or I can pop off mute and give you a response.
Okay. All right. We'll bring you back on later to see. But Kathy, you got your hand up? Sorry.
Yes, no problem, Russ. I just wanted to clarify we have one facility we have been currently working through these examples with, and we have not closed that item. That is still an ongoing effort with the University of Louisville. So if there's other examples outside of that facility, WellCare would like to see them.
Okay. I will check. Thank you.
So are you all getting denial reasons and appeal rates for those?
I can't
Like you
answer
would a
that.
normal denial?
I don't believe so, but I can't answer that question. What I understood was the hospitals are still asking what the difference is, what can be substantiated. They're not, I don't believe they are.
Okay, check and see.
I
All
will, I'll check and
right,
see.
it's considered by us a denial, so they would have to still do the reason for the denial, and then you'd have the right to appeal that, regardless of what they call it.
Yeah, Justin, on the examples I have reviewed to this point, they have each received a letter on them outlining the denial reason and the appeal rights.
Perfect. Thank you so much.
Okay. All right. Thank you. Line item denials. We sent examples, as I understand it, to DMS in August. Wanted to know if anybody has looked at them or had the opportunity to look at them. Again, these are cases where the MCOs are stripping out charges and excluding those charges either from a percentage charge reimbursement or a outlier calculation which impacts reimbursement.
So I have gotten direction that it would either be Jeremy or Chelsea that will respond to this.
I will have to take this one back, because I think Jeremy was actually the one spearheading this item. So I'll need to get an update from him. He was unexpectedly out yesterday and today, so
Okay.
apologies. But I will get an update from him and send that over to you after the meeting today.
Okay, I appreciate that. Thank you.
Yeah, no problem.
All right, just making notes. E&M down coding. So this kind of goes into what Justin just kind of mentioned, that, you know, the hospitals are experiencing E&M down coding on the ED and on E&M visits where we are not getting a letter. So it's saying that a low level of care will be paid. They've determined that, the MCOs determined that is not a level 4, but it should be a level 3. And it's going through the remittance advice. So it's going through an algorithm or a computer program or something within the MCO, and hospitals repeatedly are getting down codes to their E&M visits or ED level visits through remittance advice with no letter, no outlining of appeal rights, no reason. And it's a denial. However you look at it, it's a denial. And I guess I'm looking from DMS to weigh in, because it does not allow a provider the ability to know why. And I don't even think the MCO knows why in some cases, because they put it through a computer program, and they are accepting what's out of it. So to us, it's a black box, and we don't have justification or reasons why these are occurring, and they're occurring a lot.
And this is happening, sorry, this is Chelsea. This is happening with multiple MCOs, right? This isn't one particular
Correct.
MCO.
This is not
Okay.
one.
That's what I
And,
understood.
and we get flooded with them, and I want to flood back appeals, and I want to flood the cabinet with complaints and secondary reviews as much as I can. But in order to start that process, and I will, I promise you I will, in order to start that process, I got to have at least a reason or a way to start it.
Yeah, I mean, absolutely. And to your point, you can't appeal if you're not clear on, it's not really a denial. It's just, down, like you're saying, that it's just downgrading
Well,
it. So your kind of appeal rights are.
Well, it is a denial, Chelsea. So
right?
yeah.
I've billed X and they're paying Y, so they've denied X and said I'm gonna pay you Y, just like a DOT downgrade.
That's correct. So in any denial, we still, our expectation for any denial is that you all will get a denial reason and an appeal right, regardless of what it's called, regardless of what it's for. That's the expectation. So if you're not getting that from a specific MCO, let us know and we'll talk to the MCO about that on that specific case.
Okay, I will do that.
Thank you, sir.
Not a problem.
And don't they always base this saying that they've been given directive by the department that they're not supposed to pay for unnecessary emergency room services? So that's their justification for downcoding.
Well,
They
that's
don't look at any.
it's different though. So their justification can be whatever, but they still have to tell you what it is, and then you still have to have an appeal right.
Right, but they're blaming it on you all, that you all have
That's
had this
okay.
directive. You got big shoulders, right?
Yeah.
Yeah. And they're doing it without looking at.
And sure, I mean, we do that is part of their job, is to make sure that there aren't unnecessary emergency room visits. I mean, that's they're 100% correct on that. But we
And
still
with
want,
their, I would suggest that with their algorithms, if they would know who is over coding, they should know that. And that's the people they ought to go after instead of making everybody else submit medical records to prove what we did was right. If they have somebody that's an outlier, go after the outlier.
We'll get you that information, Justin. I appreciate it. Thank you.
thanks, sir.
All right. Any other items Rosman, did you find did we give examples?
I see where Chelsea had requested examples, and I believe that they were going to come from U of L, Danette Warford. So I think she was going to share those with you, Chelsea. If she did not, I'm going to email her after this and remind her to send those over to you.
Okay. Thank you.
Sorry, I was trying to get off mute. I apologize. I couldn't find the button quick enough. Thank you, Rosman. I searched for Danette's name in my inbox. I do not show anything received within the last few weeks. So if you don't mind to let her know to send those over, I'll definitely take a look.
Sure, I think they probably would have been sent secure because they've got PHI on them. But
Okay.
I'll double check. I'll shoot her a note and copy you on it, and that way you guys will be connected.
Okay, thank you so much.
Okay. Any other items, general discussion? Laura, you have anything?
Nothing further.
Okay. No recommendations today, no quorum to do recommendations anyway. MAC meeting representation, I will be there. The MAC has changed a little bit, and so the only report outs from the TAC, as I understand it, will just be recommendations and those discussions based on other agenda items that they're mandated to take care of. Our next meeting is December 30th. It's a Tuesday, I believe, 2025. And if there's nothing else, we will adjourn for the day. I appreciate everybody's time. Thank you.
Thank you.